everybody, I've pared down these slides a little bit. Somebody asked about anemia. Somebody's asked about anemia and polycythemia. So I thought I'd go through these anemias with you really quickly. Let's do them right quick. It's a few slides. It's going to take a little minute, but hopefully let's review anemia. Anemia is what causes a reduction in oxygen transport. There's a hemoglobin deficit. Without hemoglobin to carry oxygen, the oxygen isn't going to get there. Oxygen deficit leads to fatigue. There's less energy production in the cells. Cell metabolism, cell reproduction is diminished. Cells are on vacation. Compensation mechanisms like tachycardia, your heart speeds up to try to pump more blood, get oxygen where it needs to go. Peripheral vasoconstriction, the blood's going to get shunted to the major organs instead. General signs of anemia then are pallor, fatigue, right? Makes sense about the things we talked about, dyspnea, and tachycardia. Oxygen deficits lead to decreased regeneration of epithelial cells. The digestive tract becomes inflamed and ulcerated. There's stomatitis in the mouth. Usually if there are ulcers in the mouth, there are ulcers throughout the GI mucosa. So the inflamed and cracked lips, those cells are just not being regenerated, replaced. Hair and skin can show some of the same signs. Severe anemia can lead to angina or congestive heart failure. So, iron deficiency anemia means that there is insufficient iron. And without iron, hemoglobin's not made. And without hemoglobin, oxygen isn't carried. So we don't have iron to make hemoglobin to carry oxygen. It's considered microcytic, but doesn't that make sense? There's not enough iron in the cell. It's going to be smaller. It's going to be pale looking, so it is hypochromic, that little red blood cell. Low hemoglobin concentrations in the cells. It's actually pretty common. It can range from mild to very severe, very low hemoglobin levels. All age groups. It's more common in women of childbearing age. And there are lots of different reasons for why, but from my understanding, we aren't really sure why. Definitely puberty and things like that may come into play with women having a greater incidence of anemia. 1 in 5 women is affected, and that proportion increases if you are pregnant. It is frequently a sign that something else is going on. Now, there are lots of causes. The iron intake that is below minimum requirement is a major reason that infants have it. Infants who drink a lot of cow's milk is not iron fortified. It is not. So they're not getting iron. If you go to the store and look at all the infant formula, look at the infant cereals, they're all iron fortified. And that means as the baby loses those maternal stores of iron that they had when they were born, they can replace them. They usually start to lose them by about 6 months old. And when do they start solid foods? Oh, wait, about 6 months old. So they're going to start replacing them with the cereal, the baby cereal and baby formula that they're getting. Chronic blood loss can cause iron deficiency anemia, bleeding ulcers, hemorrhoids, even cancers. Impaired absorption of iron is another reason that there is iron deficiency. And there are a lot of malabsorption syndromes out there. And liver disease can affect iron as well as iron storage. So what are the signs and symptoms? Well, as you might already know, pale skin, pale mucous membranes, fatigue, lethargy, cold intolerance, all those things that happen when you don't have enough oxygen to your cells. They're gasping for air. So irritability, the degenerative changes we talked about before, stomatitis, glossitis, menstrual irregularities, maybe, delayed healing without the oxygen to the cells. And then your body is doing things to try to speed up the process and get oxygen out there. And that's what you see here, the tachycardia, heart palpitations even, and eventually dyspnea and maybe syncope. Diagnostic tests primarily are the hemoglobin and hematocrit. You can also look at the mean corpuscular volume and the mean corpuscular hemoglobin concentration. How big is the cell, in other words, and how much hemoglobin is in it. You can look at serum ferritin and serum iron. What do you do to treat it? Identify the cause. Are you bleeding? Do we need to stop it? Are you drinking too much cow's milk? Do we need to slow that down? But the prognosis really depends on the cause. Iron-rich foods are good. Iron supplements are good. Give iron supplements with food so that you avoid irritation and nausea. With babies who may be getting liquid iron supplements, those medicines will stain the teeth. So you don't want to mix it or dilute it with anything. You don't want to keep it in the mouth. Rinse the mouth as soon as you're done. And it says give the medicine with a straw. We've always been taught that. Little guys all can't drink through a straw. So just get it past your teeth with a dropper. And then rinse their mouth with some water. Pernicious anemia is another one, and this one is directly related to a deficiency in vitamin B12. It is a lack of absorption of B12 because of lack of the intrinsic factor released by the gastric mucosa and required for absorption of B12. What do you see in this case? Instead of microcytic, we have macrocytic, large, immature, nucleated red blood cells. You know that when a red blood cell becomes mature, it loses its nucleus. Well, in this case, it still has one. It is a nucleated red blood cell. It's very large, it's very immature. We call it megaloblastic. They carry less hemoglobin. They have a very short lifespan. They just don't do the job like a mature red blood cell would do. So we see that on their blood smear. Patho here for you, decreased intrinsic factor means decreased absorption of B12, which means deficit of B12, which means erythrocytes don't mature, which means megaloblasts are put out instead. Don't live as long. They get broken up, and therefore you're anemic. So, dietary insufficiency is rarely a cause. Genetic factors are implicated. Interestingly, it's more common in light-skinned women of Northern European ancestry. The chronic gastritis, we talked about being able to absorb, is usually something that accompanies it. Gastric surgery can also cause problems with B12 deficiency. It's not absorbed. It's needed for the function and maintenance of neurons, B12, and so symptoms in the peripheral nerves will occur if there is a lack of B12. Demyelinization actually will occur with a lack of B12. Most of the time, these are reversible. So, in addition to all the usual anemia manifestations, look at a few of these other things. The tongue is enlarged, red, sore, shiny. Stomach aches, digestive discomfort, nausea, diarrhea, pins and needles, and tingling in the limbs. What do? You look under the microscope at the red blood cells, get a smear, and you look. Do you see nucleated, large red blood cells? You can look at the bone marrow and you can tell that it's hyperactive and is making a large number of these immature red blood cells. You can also measure serum B12 and tell that it's low. Presence of hypochlorhydria and achlorhydria show gastric atrophy. And there's a test called Schilling's test, where you give radioactive B12 and measure to see if it's absorbed. Oral supplements are what's given usually as prophylaxis. In the case that replacement is needed, B12 injections are given. You may have seen this. B12 is that red injection. Aplastic anemia is a absence. The bone marrow goes on vacation. It says, I'm not working anymore. I'm not making blood cells. So it shuts down. It does not, start over. Not only does it not make red blood cells, it doesn't make white blood cells. It doesn't make platelets. It doesn't make anything. So you think about what happens if you don't have red blood cells. Anemia, right? What are the signs and symptoms? All that fatigue and lethargy and high heart rate, all those things. What happens if you don't have platelets? You bleed. You have bruises. You bleed spontaneously. And finally, what happens if you don't have white blood cells? You get infected. You run fever. You cough. Aplastic anemia can be temporary or permanent. It can be either. We don't always know what causes it. There are some antibiotics that I have seen cause aplastic anemia. Most of the time we say it is idiopathic, because idiots don't know the pathology. There are things that can cause it. The myelotoxins, things that are toxic, are cause myelosuppression. The radiation, industrial chemicals, other drugs. We talked about antibiotics. Viruses, hepatitis C can cause aplastic anemia. And then there are some genetic abnormalities like myelodysplastic syndrome and Fanconi's anemia, which you'll learn about later on, I believe. Blood counts indicate pancytopenia. Everything is gone. You've got low red cells, anemia. You've got leukopenia. Your white cells are not there. You've got thrombocytopenia because no platelets are there. We do a bone marrow biopsy and we can see that it is not working. The erythrocytes often appear normal. So what that means is it has lost its nucleus and it looks mature. There aren't immature ones. There just aren't enough of them. It quit making them. So there aren't immature ones being put out. There aren't any being put out. The ones you see will look like normal red blood cells. If the patient is on any kind of bone marrow suppressant, they need to come off of it immediately. We need to treat this cause because obviously, if you can't stop bleeding, if you can't fight infection, if your tissue can't get oxygen, it is life-threatening. Bone marrow transplant for the ones that do not recover is the treatment. Okay, hemolytic anemias. This is when blood cells, red blood cells, are destroyed. They are lysed. Hemolysis means the heme is lysed. It is broken down. There's destruction of red blood cells faster than they can be repopulated. Genetic defects, immune reactions, changes in blood chemistry, certain infections like malaria, blood toxins, antigen-antibody reactions can cause hemolytic anemia. Incompatible blood transfusions is what you think about there. Erythroblastosis fetalis, you will probably hear about later on too. Sickle cell is one of these where there is a hemolytic anemia. It is hemolysis. It is autosomal recessive. Both parents must have the gene and pass it on. Now, it can be the person who is a carrier who only has one gene usually has no serious complications. They may have some minor things to go on, but this sickle cell anemia, I call it sickle cell disease, anemia is a symptom, is autosomal recessive. There is diagnostic testing. We do this with newborn assessment. It is more common in individuals of African ancestry. And we know that if you are a carrier, if you just have one gene, that it's protective against malaria. Um, so 1 in 10 African Americans is heterozygous for the trait. I put a little Mendelian square worksheet on there for you today. Go back and look at that. It's in the files, and it has some of these squares for you to work out and try to determine inheritance. I hope it's helpful. So you've got an abnormal hemoglobin. Instead of having normal adult hemoglobin, which is hemoglobin A, they have abnormal hemoglobin, which is hemoglobin S. Sickle cell crisis occurs whenever the oxygen gets too low. Anything that causes hypoxemia. The sickle-shaped cells are too large to pass through the microcirculation. What happens is they sickle. They turn into long, skinny, spicule type things, and they have very sharp, pointy ends instead of a nice, round, fluffy, donut-shaped red blood cell. And so these little spicule, sharp, pointy ends catch and block and occlude in the blood vessels, especially the little tiny ones, hands and feet, arms, fingers. So it occludes, and with that obstruction, multiple infarctions and necrosis will occur if we don't get blood moving. Multiple infarctions. You can have a brain infarct. Children with sickle cell disease have strokes as a result. Bones can infarct. Any organ where blood goes, which is any organ, can infarct. Other things you're going to see, jaundice. The cells are rapidly breaking down so fast that these things are being accumulated. Gallstones, hyperbilirubinemia. There's just such a high rate of hemolysis that all of the components of the blood cells are constantly being released in those high numbers. Clinical signs don't usually appear until the child is about 12 months old. Until then, somewhere around 9 to 12 months, the child has fetal hemoglobin, and fetal hemoglobin does not sickle. As the child gets older, the fetal hemoglobin is replaced by whatever their genetic hemoglobin is. Hopefully, it's hemoglobin A, which is adult, but if they have the sickle cell gene, then it's replaced by hemoglobin S. And so at around 12 months, they will start to have symptoms. Primarily, this is pain because of tissue ischemia and infarction. But pallor, weakness, tachycardia, dyspnea, again, you're looking at an anemia, right? We talked about the hyperbilirubinemia and the jaundice. Splenomegaly, things are just accumulated there. Cellular debris. Vascular occlusions and infarcts in the lung, in the small blood vessels, in the brain. Growth and development is delayed, and congestive heart failure is a possibility. Diagnostic tests include a hemoglobin electrophoresis, which will tell you whether hemoglobin is S or A or D or thal or all of the others. There is prenatal DNA testing that can see and identify sickle cell disease. I already talked about, but I'll just say it again right quick. Hydroxyurea is actually very good to prevent sickle cell crisis. It keeps my understanding is it causes the person to continue to make hemoglobin F, which doesn't sickle. So, but hydroxyurea is a chemotherapy, so it has its own set of problems, and so you can't just give hydroxyurea to everybody across the board. Dietary supplementation with folic acid will help somewhat, but remember, this is not a problem with not enough iron. The cells are just destroyed. Bone marrow transplant. We say that sickle cell is not curative. It's not. You can't cure it. Potentially, bone marrow transplant is curative. But again, it has sometimes more severe problems than sickle cell. And so it's not going to be routinely done on every patient with sickle cell. Because they have a weakened immune system, you're looking at immunizations against pneumonia, influenza, meningitis, above and beyond what maybe other children get. So we talked about some of these things. We talked about megaloblasts and pernicious anemia. We talked about aplastic anemia, where all the blood cells are affected. You'll see normal cells. We talked about iron deficiency, where there is a microcytic, hypochromic, small and pale cells. And then we talked about sickle cell, where the cells are lysed and are shaped like a sickle. Now, this question was asked too about polycythemia. So let me go back over polycythemia. Primary polycythemia is called polycythemia vera. Essentially, your body makes too many erythrocytes. It makes too many erythrocytes. Sometimes it makes other cells too. The bone marrow just makes everything. It pushes them out. Your book calls this a neoplastic disorder. That surprised me, but I guess it is because it's a proliferation of erythrocytes. So the person has a high hemoglobin. They'll have a high number of red blood cells. Secondary polycythemia is erythrocytosis. It increases in the red blood cells in response to, like prolonged hypoxia. Your body says, I need oxygen. So the bone marrow works overtime and puts out some more red blood cells. If there's erythropoietin secretion that is increased, then the body may make more red blood cells. It's a compensation mechanism, kind of, to get oxygen to the system. Okay? All right. So a person with primary polycythemia, you would think, well, they can just give blood and get rid of some of those red blood cells. But then the body says, oops, I don't have enough red blood cells, and it may overproduce even more if that's the case. So you have to be very careful with polycythemia about removing blood. What are the signs and symptoms? Distended blood vessels, sluggish blood flow, increased blood pressure, hypertrophied heart, hepatomegaly, splenomegaly, lots of cells going through those organs. Headaches, dyspnea, the things that you would expect, right? Thromboses, infarctions. We talked about diagnostic tests. Increased cell counts, increased hemoglobin, increased hematocrit. The bone marrow is going to have all of these cells in it being pushed out. Possibly hyperuricemia. They're broken down, these cellular elements. The treatment is to find out what's going on. Radiation is a possibility to try to get the bone marrow to slow down. You want to be very careful and not slow it down completely, though. Periodic phlebotomy, and that's what we talked about, removing blood. You just have to be careful not to remove too much blood because you don't want to trigger the body to make more red blood cells. Indications of blood clotting disorders, and these are listed for you here. I haven't had any questions about these, so I think we're going to keep going. Hemophilia A, I've only had some questions on these related to the sex-linked recessive, and I think that the worksheet I gave you is going to help with these. Let me know if it doesn't, or if you still have factors, if you still have questions about X-linked recessive and what that means. Okay. Nothing about DSC. I haven't had any questions about that. Acute and chronic leukemia is a little bit. No real questions about that, and we've talked about that before. If you have questions about the leukemias, let me know. Here's a list of the types of leukemias. Acute lymphocytic leukemia can be any of the lymphocytes. that can be affected as malignant. They're making too many of them. They're very immature. They don't work. And that's true for all of these. They don't work. So it looks like there's a lot of white blood cells, but they're not doing their job of fighting infection. Okay, I should probably just stop here. Let me click quickly to the end. That's a picture of a leukemia cell. All right, if there are questions about any of this, you guys, please let me know.